Today, I'm very excited to introduce Dr. Rebecca Hamm. I almost said Feldman, but she's an assistant professor at the University of Pennsylvania. I have known Dr. Hamm for quite a while as we were residency classmates together. She stayed at Penn for fellowship in maternal fetal medicine and then joined the faculty. She's a leader in and nationally known in implementation science and maternal outcomes, and leads multiple NIH grants and is just an incredible human. I am very proud to have known her and and I'm very excited to welcome her here today.
Hi guys, thank you so much for having me. It's really hard to hear about yourself. I don't know. So I'm going to be talking today about evidence-based induction, which is a kind of charged term, I'll say. I think a lot of work, if you go to SMFM any year, right, there's like 6 new RCTs about different aspects of induction. They all contradict each other, and there is a ton of different data. And so I will just warn everybody that term has different meanings to different people. I am an implementation scientist, which Laura mentioned. The concepts of implementation science, we don't have time to do implementation science 101 today, but I am going to try to weave some of the ideas of implementation science into this talk. Implementation science means that we have a huge evidence to practice gap in obstetrics in all of OBGYN and women's health. Meaning that we make new evidence every day. The Green Journal comes to our houses, it's filled with stuff. We cannot possibly get all of that into our care and make change every day in a way that works for both us and for our patients. And so implementation science is the study of actually how to get evidence-based practices into care. And sometimes that process can be very long and rigorous and hard. And so we're going to be talking a little bit about some of the pieces of implementation science throughout some of my projects today. All right, I have no disclosures, but my research is all funded by the NICHD. So we're going to be talking about induction today. And when I talk about induction, there are obviously many patients in our world who need to be induced or who elect to be induced. But the caveat is that most of this work is around patients undergoing induction with intact membranes and an unfavorable cervix that are not TOLACs and not PROMs and not fetal demise inductions. These are, your kind of medically indicated and elective post-AIDS induction people. We know that induction is going up. Everybody knows this, right? It's the struggle of all of our labor and delivery units that in the last 10 years alone, we've gone to induction rates in the 20s around the country to induction rates in the 30s. And that 10% rise is a huge impact on our patient care, on our strain on our infrastructure on labor and delivery and the resources that we have. And so it just underlies the importance of working in this space and that we need to, today's talk is not really about like whether people should or shouldn't be induced. This is about how to best induce people once that induction decision has already been made. So we'll skip that controversial part. So we also know that the rate of induction really varies by geography around the world. Overall, worldwide, it's around 10%. But I think that people don't often think about the rates in other countries, but induction rates are still, somewhere between like 5 and 10% in most other places around the world, but obviously highest here. The reason that it's different across countries are the availability of some of these drugs, monitoring facilities, healthcare staffing, but culture and adherence to guidelines and protocols, and especially variation in elective induction trends are what drives some of those differences. Okay, so I'm just going to briefly touch on ARRIVE, which is the idea that we had a randomized trial that took a look at patients in the nulliparous patients who are uncomplicated in their 39th week and randomized them to induction versus awaiting spontaneous labor, and it was shown to be associated with improved outcomes, reduced cesarean rates, reduced hypertensive disorders. But that doesn't change the concept that for our patients who do need an induction or show up for an induction at whatever gestational age, rather than arriving in spontaneous labor, right, which is the different and sort of wrong comparison before arrive, but those patients are still at increased risk of C-section and choreo and postpartum hemorrhage and decreased birth satisfaction. We know that patients who require an induction as compared to patients who don't require an induction have lower birth satisfaction and racial disparities in their birth satisfaction as well. And so the point being that induction is a great target to sort of reduce some of these outcomes, and that when we're thinking about reducing our primary C-section rates, parts of induction are a way to target that as well. Okay, so I'm going to be talking about two major different interventions throughout the course of the day today. So a cesarean risk calculator and then standardization of the induction management. There's not like a clock anywhere up here, so someone you give me a sense of how I'm doing throughout all
Do
this.
you wanna watch or you have, do you wanna watch or anything? Do you have a clock?
I can grab my phone or something, so I have any idea what I'm doing. Do your phone. Okay, great. We have till 20 now?
Yeah.
Okay, great. All right. So introduction to this cesarean risk calculator concept. We know that approximately a third of our inductions will end in C-section nationally. We all know that C-section is associated with morbidity, obstetric hemorrhage, and surgical site infections, TE. But really, you can all think back probably to your last few weeks, for those of you that practice OB, and it's those really lengthy and then failed inductions that result in the highest maternal mortality. And if we could theoretically predict, which patients were going to end their induction in a cesarean earlier on, we could help our clinicians manage that patient better. We could help that patient have better expectations. And the opposite is also true. If we knew which patients were going to end in a vaginal birth, that would also help us make better decisions for both from the clinician side and the patient side. We, talk about racial disparities in OBGYN all the time, but one of the things that's talked about less is the disparity in cesarean delivery rate. We know that our non-Hispanic Black patients are about 10% more likely to undergo cesarean, even when controlling for all other differences between groups. And so that is part of the idea that you need to tackle here. I think we spent a lot of time in the last 20 years describing disparities, but not a lot of productive, innovative solutions that have actually solved it. And so, one of the things that our group works on in this space is the idea that OBGYNs, no matter how much we think well of ourselves, are not immune to bias. We know that implicit biases impact decision-making, and there's a plethora of data that they impact our decision-making across women's health. And one method that has been studied in various projects to sort of reduce this idea is to increase objectivity in your care management, thereby minimizing variation in how we practice that theoretically would reduce some of these disparities. Now, I always say that that is a Band-Aid, right? It's not in any way a solution to the roots of the problems that cause these disparities or cause bias in care. But if we can, in the urgent need of fixing some of these issues, if we can increase objectivity in how we're taking care of patients, we have a chance of reducing some of these disparities. We also, the last thing I'll say here is that labor induction, as I learn about sites across the country, is so different at different places, right? It is different by provider, it is different by patient population, by site, and so much of that is driven by many things, which we'll talk about in some of the qualitative work that comes up later, but this is really an ideal target for trying to standardize processes. So this is the first tool that we sort of use to think about to standardize processes. So this is a calculator that can predict likelihood of C-section at the start of labor induction. So we initially developed it at Penn in about 500 deliveries and then validated it in about 200,000 deliveries across the country in a database of over 20 hospitals with lots of different practice models and lots of different patient populations. And it was always meant to be really simple. It has only 5 components: height, BMI, parity, gestational age before or after 40 weeks, and their cervical exam at the start of the induction. Now, it's available if you ever feel like playing with it. This is a screenshot of our website, which I'll show you a little bit more later, but it's www.iccsectionrisk.org. But if you go there, you can put in patient's information and it will give you a personalized risk of C-section. All of this is no PHI, of course. And the idea was that this would be a snapshot in time, right? That we could go up to a patient at that moment of starting their induction and have a conversation about personalized risk in that moment. This is not fancy. This is not machine learning, right? This is not meant to sort of change throughout the process. But, I think that the clinical applicability of some of those things that, like, if we're thinking about variables that change all the time, we're not going to be constantly having that conversation. No one's going to put a screen in a patient's room and say your risk went from 12% to 14 because of that exam, right? And so, like, this idea is, we can actually talk to a patient about these results. So you'll see an example here, a patient who's 5'7" with a BMI of 36 and is multiparous and is 40-1 with an exam of 1, 3, and -3, has a 16.5% chance of a C-section. Now, people automatically get worried here, right? So it's normal to have that feeling of like, oh, this is bad. I think that's everyone's first reaction. And so we'll talk a little bit more about that in a minute. But the first caveat that I make for the this is bad feeling is that the highest risk you can get on the calculator is 77%. Only about 2 to 5% of patients get over 60% on the calculator. So the vast majority, 95 to 98%, are less than 60% risk. And so it's those highest risk patients that we're trying to identify, but those are pretty rare in this data set. And we'll kind of talk about how we sort of manage those things over time. And so essentially the way we put this into care initially at Penn we used this external website. The admitting provider had to recognize that the patient was eligible for the calculator. And again, it kind of goes back to that criteria we talked about at the beginning on the top, which is these were term inductions of a singleton gestation, not prom, not TOLAC, unfavorable cervix. They would go to the calculator and get the risk. They would use standardized scripts that we developed with patient feedback and clinician feedback to have a conversation with the patient about that risk. They would, we had a handwritten board at the time. Now everyone's changed it to like the fancy Epic boards, which I hate. I miss the handwritten board very much. But they would write it on a sticker and put it next to the patient's information so that everybody on labor and delivery could, have that information while they're going through the labor course. And really importantly, we didn't dictate any changes, right, in clinical care that had to be made based on the score. This was not about, making people recommend a C-section in some situations or not. This was very much just meant to be a piece of information in the back of both the patient and the clinician's mind as we deal with those gray areas of decision-making throughout labor every day, and help them make decisions in that space. And so when we did that, we did initially a year pre and post implementation study, very simple study design, to look at this practice. And see if we could look at C-section rates and maternal morbidity before and after. And so there's about 800 patients in each of these pre and post implementation periods. And essentially what we were able to show by putting this calculator into care is that we had a significant associated with significant reduction in C-section rate and maternal morbidity, specifically around hemorrhage and infection, and an increase in patient birth satisfaction. And when we looked at that more in depth, it really seemed to be the morbidity changes were really driven by the changes at the extremes of cesarean risk. So people in the really low risk groups and people in the really high risk groups. And this is where implementation science sort of starts to come into play in how we can understand quantitative data, as well as understand if we were going to take this piece of data and actually try to put this intervention into care at different sites, at different populations, at a scaled up level, how are we going to be able to do that well? And so the way to do that, in my mind, is qualitative work, which is a big tool of implementation science, where we essentially we did 20 interviews with clinicians who were involved in utilizing the calculator in that initial study. And we interviewed about 40 patients who had experienced use of the calculator during their induction. And we, made sure that in our clinician work that we purposely sampled by role. We know that there's lots of different perceptions of this, particularly most healthcare interventions actually, by role on labor and delivery, right? We needed to include our nurses and our midwives and our trainees and our attendings and our family medicine. We have a family medicine service, all of those people in the conversation. And then from a patient perspective, we wanted to really make sure that we sampled across the range of cesarean risk, as well as how they ended up delivering. We needed to, talk to people who were told they had a really high risk, but ended up having a vaginal delivery. We needed to talk to people who were really low risk, but ended up having a C-section. We wanted to talk to all of those people to understand their experiences. And I think the first thing that I'll say is that we were much more able to understand the mechanisms of effect of the calculator by having this qualitative data, which was the idea that in the low risk patients, clinicians told us that knowing that increased the confidence in achieving a vaginal delivery. Same for patients. And that by doing that, we actually saw a significant reduction in C-section rate in those groups. And the C-section rate was about halved in the already low risk group. And we completely eliminated C-sections for failed induction in the patients who had a less than 20% score. And in this case, I think the idea is that we then prevented maternal morbidity associated with those C-sections, right? All those hemorrhages and infections that occur just because someone had a C-section. Now in the high risk group, things were a little bit different. We saw a significant reduction in maternal morbidity. The C-section rate did not go up, but it did not go down, right? It was about the same from our pre to post period. But what we showed was a significant reduction in time to C-section by about 5 to 6 hours in those patients. And again, what patients and clinicians told us is that it helped them come together to make the decision for what ended up being a necessary and then, essentially inevitable C-section for that patient a little bit sooner, right? Not every patient in that group had a C-section. The C-section rates were still, around 60% in that group. But just prevented the maternal morbidity associated with those really prolonged and then failed inductions. And I'm sure you can all imagine some of those situations, right? Failed induction is one of the easiest examples to give, given those sort of big ranges of someone who's on Pitocin and ruptured for this amount of time, we're going to call a C-section for failed induction. You might think about how that impacts here. And so what clinicians told us at the end of the day is it really helped them provide objectivity in some of those gray areas. And that theoretically, this is what helped us take a look at the data and see that we had hints that this might reduce disparities in C-section rates as well by sort of decreasing some of the bias going into the decision-making around cesarean. But we were not powered in any of that initial work to evaluate disparities in outcomes. We did, in terms of disparities, be able to show a reduction in our pre-period. There was a significant disparity in birth satisfaction scores on this validated scale between our Black and non-Black patients. That was eliminated in our post-implementation group. And it looks like the satisfaction went down if you kind of look at this. This is the percentage of people that were below the median. So it's actually fine that they even out. But the idea being that our satisfaction scores were the same by race in our post-implementation group. And, I think people told us that people started having more standardized conversations around induction. I think it was a little hard in qualitative work with patients to understand why this was happening. But the idea may be that, people were going in and having a detailed conversation about induction at all at the beginning of the induction, which they may not have been in the pre-period. And so we heard, a lot of feedback from both low risk and high risk patients. I think that the low risk patients essentially told us that the calculator either didn't have any impact at all. They were like, of course I'm having a vaginal delivery. I don't know what you're saying. Or they made them feel a sense of comfort around the idea that, oh yes, I thought I was gonna have a vaginal delivery, but now you told me I am, so that's great. Or the high risk patients, there certainly were a few people who told us it increased their stress during labor, right? People worry about stressing their patients out in labor. That's not a totally unreasonable concern. There definitely were patients who said, I walked in, I had no idea that I was at an increased risk of C-section, and then I'm about to be induced and you're telling me I have an increased risk of C-section. Probably you should have told me that earlier. And then, other patients told us that they thought that this was a really helpful conversation rather than being blindsided sort of later on in the process. And then when it came back up, when they were 18 hours ruptured on PIT or whatever, I think it was helpful for them to have heard that they were at high risk. But there's lots of limitations of this work, right? This is just at Penn in our single urban, very academic unit. It was a simple pre and post evaluation that doesn't control for any secular trends, other things that could have been going on at those same times. And we were not powered to evaluate the impact on disparities. At the end of both the qualitative pieces, we essentially had lessons learned. We spent a lot of time in those interviews evaluating kind of what made it easy to use the calculator, what made it hard, and came up with a list of suggestions, essentially, from both perspectives that would help make the calculator easier to use in the future. People said, we need to be talking about this in prenatal care. People shouldn't just show up and here they have a C-section risk. We should even consider calculating a preliminary score in their prenatal care, even though it might change when they get there with their cervical exam, et cetera. It needs to be in the electronic health record. Who's gonna go to your stupid website? We heard lots of things like that, like, you know, that people needed a visual aid to help explain this, right? Risk is a really tough concept for patients to understand. And so that was a piece we heard. And that, you know, clinicians didn't have time to do all this counseling themselves. Can there be a video? Can there be something else to explain it to patients in a way that makes sense? So the next step in the work was electronic health record utilization. And so we got some funding from we have something called a nudge unit. I don't know if you guys have anything like that here, but essentially to sort of help you make EHR changes in a way that doesn't restrict choice, but allows the clinician to still be like an active participant in decision-making, which is apparently the best way to make EHR changes. Nudge theory I've learned a bit about. But essentially, you know, they helped us incorporate it into a way that works, and I'll show you in a second. You guys use Epic on labor delivery. Yeah. So this was really another simple sort of study, you know, a 6-month pre and post period. We implemented the calculator at a second site at Penn. You know, site number 1 was the site we had already done this at, where we had put the calculator into care to some degree already. But we didn't I didn't keep harassing people about utilizing it from 2019 until this time in 2022. So certainly use went down over that time period of the external website. And site number 2 had never specifically implemented it. And now, you know, in this new EHR integration, essentially we incorporated the calculator into the EMR. When the other steps are the same. We still wanted the provider to go and counsel the patient on the scripts. They could document it in the EMR through the integration package, and continued that, you know, management was still up to you. And I have this, let's see if this video works actually. I probably should have tested this before. Okay, can't hear it. That's fine. Okay, so I'll show you what it is, which is that there's a column on the side here for C-section risk. So you guys probably have an Epic grease board. This is like a training grease board, so obviously it looks like a disaster. The system automatically determines that patients are not eligible by that, you know, if they've had a prior C-section, they already came in ruptured, they're already too dilated, kind of with this cross circle here. If the system doesn't automatically determine that they're ineligible, there's a little question mark there. You can double click on it, which it'll show you in a second, I think. Yeah. And then you can confirm the patient is in fact eligible and that the patient is being induced, because the system actually has no idea how to tell if someone's being induced or not. So annoying. And then you say, yes, please calculate the score. And then you refresh, and then a score comes up for you there. Sometimes you don't have a cervical exam in there, or their cervical exam has changed by the time you want to start the induction because it pulls in their first exam. You can update the exam in there by putting their exam in, and you refresh, and then it gives you your risk. It also gives you the wording that goes along with the counseling that comes there. And then you'll see that the score appears in the column there for everyone to see. And then if you were to decide that they, you know, didn't qualify, you would click on that again. Don't calculate the score, tell me why, so that we can keep that data. Actually, it's twins, and no one put that in her chart. Laura was telling a story last night about how she found a mysterious twin. And then the last thing that you can do is kind of auto document this. So you kind of click on that blue box there, and it pre-populates a progress note that actually pulls in the C-section risk, as well as language that was approved by our legal department as okay language to put in the chart around this, and you can sign it. And so that was how we built it, which is like a 2-minute video that took like 2 years of my life, as you can imagine. And when we did that, in this study at the 2 sites, you know, we had about 1,000 people in each group. In the pre-period, you know, even the site that had implemented into care was probably down to like 20% utilization. Obviously, it was like 0 at site number 2. And so our utilization in the pre-period went from 13% to 77% with the EHR integration. And at site number 2, actually, I don't think I have a slide on this. It went up to like in the 90s. They went from like 0 to 90. I think that like the people that had already been using it a little bit were, you know, the EHR integration wasn't as exciting and novel to them. But We're still somewhere around the 70s at both sites, which is great. So now that we have that in place, we move on to some of the more complicated implementation science study designs. We have an idea that this is effective in the real world to some degree, but obviously every labor and delivery functions so differently, and there's a possibility that the impact of this calculator could be different in different practice models. And I think that's something that a lot of RCT type research doesn't recognize, which is that because of the differences between sites, we actually could have differences in effectiveness at each place. And so this is something called a type 1 hybrid effectiveness implementation trial. Now, for those of you who have any sense of implementation science, it's really basic, but the hybrid trials in implementation science, there's type 1, type 2, and type 3. It means that we're looking at both effectiveness outcomes, so it means clinical outcomes, things like maternal morbidity, C-section rates, and implementation outcomes, things like, are we actually using the intervention? We're looking at acceptability from patients and clinicians. We're looking at fidelity. If we're doing a thing, are we doing it right? We're looking at cost. We're looking at scale up, things like that. And so a type 1 values the clinical outcomes still as most important, but begins to look at implementation outcomes. Type 2, the same. And then type 3 is implementation outcomes are more important. And secondarily, we're just taking a look at effectiveness outcomes. And so this study is called a stepped wedge randomized trial. And so essentially we have 14 labor and delivery units. This is an ongoing study. I'll tell you a little bit about all around the country, different geographies, different practice models. And they are randomized to start times of implementing the calculator 10 weeks apart from each other. So that adds some amount of rigor to the idea that this is still essentially a pre-post study, right? Every site has a pre-period and a post-period. But it gives you a little bit of more control for secular trends over the course of time because you've randomized to these different start times. And so our aim 1 of this study is really a big implementation science piece, which is that people just used to go into an RCT and say like, okay, we're doing RCT at like 20 places around the country, and like we're gonna get a grant, and we're gonna begin day 2 is gonna start the RCT at all these places, right? When in reality, you need to spend some time figuring out how it's going to work at each place. And so that's what we really built into this study. So year 1 was all about how we were going to fit in to the workflow and the culture and make this acceptable in each place. And so at each site, we identified site-based implementation teams, which we really wanted to be very multidisciplinary, including, everything from our physicians to our nursing leadership to doula representatives or patient advocates or whoever they wanted to be a part of their team. Then we sent out a survey that was really about acceptability and what do they think the biggest barriers and facilitators were going to be to all of those people. We brought that data back to leadership team meetings that really helped us, get in depth into the workflow. Like, who admits your patient, who then checks their cervix, and then who documents that in the EMR. Like, I have learned so much about these places. Fascinating. Like, I feel like I, having trained at Penn, as Laura said, most of my life, like we have some sites in Utah that I found the most fascinating, where it seems like a physician just like shows up when the baby comes out. So like, who's going to counsel them? I don't know. And so, I think the other thing that we really wanted to understand in these meetings were, are there different patient populations being taken care of in different ways on your labor unit or by different types of providers that could thereby impact whether there's going to be disparities in who's going to receive the intervention or not. And that sounds maybe hard to understand, but like, for example, let's say you have a resident-run clinic who takes care of primarily a Medicaid population at your site, and that population then is more likely to be patients of color as compared to your faculty practice, who is taking care of, a different patient population, and then they come to labor and delivery, and maybe they're still divided in some way where different people are taking care of them, and is one group more likely to use the calculator versus not, and then we're going to have disparities in our utilization. And so we really wanted to tackle that from the very beginning. And then we brought all these plans back to focus groups with clinicians to try and come up with finalized plans that were going to be acceptable to all these people. And the plans were not just about, the workflow, but also what implementation strategies we needed to get into care. And so we really tried to target reach across all the populations with these planned implementation strategies. We had some set ones that we thought every site needed, right? Everybody needs education and training to get something into care. Everybody needs to utilize, have local champions, these leadership teams. But We left some things up to choice of each site. Do they want to do the EHR integration like we did? Do they want to have a visual aid available for counseling on their labor and delivery unit? Do they want to have a structured plan to discuss the calculator in prenatal care? And so, these were the strategies we talked about, which is like informing patients about the calculator prenatal care, the EMR, and these educational materials primarily. These are now all available on our website. So if you go to this, you can see all the resources on here. The calculator itself is on here and all of our papers behind it are. But this is the education sheet that we came up with. Again, like one slide, one tiny page that took a lot of people's input and work. And essentially this itself went through health literacy committees as well as patient group committees to come up with that can be used either inpatient or outpatient. We came up with a patient education video that's about 2 minutes long that has a similar process behind it. And this is the final visual aid. Like, I cannot tell you how many. I think there were actually like 1,000 different versions of this visual aid. But here we are about, counseling on risk in a way that was understandable to patients. And so at the end of all that work, at the end of year one, which was in summer of last year, we had these 14 very unique plans about both workflow and implementation strategies. We also had, a plan for how we were going to do education at each of these places, like who needs grand rounds and who needs, nursing huddles and who needs, to come to resident didactics or midwife meetings or whatever it is. And so I'm going to all those things at all these places. It's very funny to me. Okay, and then at the end of the day, we are now in this randomized rollout 3-year period. We've implemented at sites 1 through 4. Still have 10 more to go. But it worked. It's worked so far. They have all those 4 decided to do EMR integration and released it on the day of their implementation. I don't think that it's going to be as smooth for every single site, but we should be able to take a look at both overall outcomes in C-section rate and maternal morbidity, as well as our now power to look at disparities in those outcomes, and be able to understand based on, we're taking tons of data around the context, right? Like around what each of these sites are and how they function, and do these things play out differently in those different places. We are still looking at implementation outcomes. So like I said, this is still a hybrid trial where we're going back to clinicians and saying, how do you feel about this now? They've been using it for 3 to 6 months. Like, is this acceptable or not? What could make it better for you? We will be doing continued qualitative work. We'll be looking at use of the calculator across all these places. And then we're going to be looking at REACH, which is use of the calculator by race, ethnicity, insurance status. We have an advisory and equity board made up of a combination of patients and physicians and PhDs kind of specialize in this type of work, who helped us kind of come up with solutions when we were struggling with how we were going to get it implemented equitably in the first year. But now their role is really, we're presenting the data of REACH. Are we using the calculator equally across race, ethnicity, insurance status at each of these places every 4 months, and are saying, do you have, we're bringing the leadership teams from those sites to meet with our advisory board and, trying to come up with some solutions early on, right? The goal is, I think in research used to be that we should just we planned a study, we're going to do the study the way we planned it from start to finish, right? But, I think our goals in research have changed, and that my goal in doing this work is to improve health at the end of the day. And so, I think that our hope is that we will be able to adjust throughout the course of the study, and maybe new strategies are going to need to be coming up throughout the process to be able to fix that. And then, in doing all this work, our hope is that we have an implementation toolkit at the end of the day that has some generalizable concepts that people could use across whatever site to do this, but that there will also be some site-specific type things. Like if your site functions this way, then it might be best for you to implement it in a specific way. Okay, I'm gonna move on to the next piece, then we can talk about questions. All right, so standardization of induction management is the next piece. So this kind of comes back to the same concepts we talked about before, which is the idea that by standardizing and sort of requiring people to at least recommend induction in a certain way, we could be putting a Band-Aid on practice variation, which is a huge issue that leads to racially disparate outcomes. So this idea started with a trial that happened to Penn that Laura and I had to enroll women in when we were chiefs. We were basically this was a tough study. So there was a randomized trial happening at Penn on different ways to start an induction for patients who met all this criteria that we were talking about. So they were randomized to either meso alone, Foley alone, meso plus Foley, or Foley plus Pitt. And everyone who decided to be a part of the trial and was randomized, to whatever their start piece was, they had a very strict standardized induction protocol to manage the rest of it, because the goal was to really isolate that start of the induction piece as what was, how did that impact outcomes. And there's about 491 women in the trial. Then, there were lots of women who told us, I don't want you to randomize me to the start, but you can collect data on my induction, but that's it. And so there was about 360 women in that observational group where they were managed completely at their provider discretion. They didn't have to have this standardized induction protocol. Now, the major concepts in the induction protocol were sort of regular cervical exams, at least every 4 hours in latent labor and at least every 2 in active labor. Again, all these patients are being induced, so, with the goal of moving things along. Amniotomy by the first exam at 4 centimeters, if feasible. And then active management of active labor dystocia, essentially, if they're not making change, starting it, not making change, then rupture if they weren't already, or placing an IUPC. And so when retrospectively, we looked back at the patients who were in the RCT, the people who had the standardized induction protocol versus this observational cohort, you started to see that there was some benefits of standardization. And so this is a paper of Lisa Levine's, who is one of my mentors, which showed a significant reduction in NICU admission and neonatal morbidity with utilization of this protocol. And then when we dug into it even more, there was a real finding that seemed to be around disparities in different outcomes. And so neonatal morbidity, you could see that when you looked at just our non-Black patients, there was not a significant difference, and a slight reduction, but nothing crazy significant. But for our Black patients, we have approximately a 60 to 70% population of Black women at the single site where this study was done at, there was a significant reduction from 9% down to 3% of neonatal morbidity when you were using the labor protocol. And then in C-section rate, there was no difference in our non-Black patients, but again, a significant reduction for our Black patients from about 35% to 26%, even when controlling for differences between the groups, and that statistically reduced that racial disparity in cesarean delivery rate. Now, that's all retrospective, right? And, there was a lot of possible reasons why that was going on, but this idea that maybe that standardization process actually might have an impact. And so this is my K project, which for those of you, I feel like sometimes when I was a resident, I had no idea what all these letters meant. But a K is like a career development grant that you can kind of get, that bridges you from training into investigator life in your future. But it's a great way to sort of protect your time and do some research. And so this was a 2-year pre and post implementation project where we were implementing the standardized induction protocol at 2 sites. And our overall goal was to improve overall outcomes by increasing active labor management practices, but then secondarily to minimize that effect of implicit bias and therefore reduce our disparities. And similarly, we were looking at, this was my first time really looking at implementation outcomes, sort of using a mixed methods approach. Again, understanding that all of the steps of labor induction are controversial. So we wanted to look at acceptability from both patients and providers, and fidelity, are we using the intervention correctly? Then, again, 2 slides that are like a disaster looking, right? This took so long, and this is the prettiest we could get it. But these are essentially the latent labor pathway, and this is the active labor pathway. The concepts were very much the same, but again, went through, many multidisciplinary committees before we had this. I'm going to take a brief, because Laura said, that this is the beginning of an academic year and we should talk about induction and evidence behind induction. I shouldn't just talk about my own research, which is fair. And so this is, a very brief into the evidence behind the pieces of the induction protocol. But what I will say is, again, that you could pick and choose, you could find a study that says anything you want about induction. But these are the pieces that, we felt like were important in including in the study. So I already kind of prefaced what the Formami study was, which was around combination cervical ripening with the primary outcome of time to delivery. And in this study, they did show that combination ripening, either meso plus Foley at the same time or Foley plus Pitt at the same time when you're starting an induction, had a faster time to delivery than any single agent method. And then when censored for cesarean, adjusting for parity, if you got mesofoley, you were almost twice as likely to deliver before women who got meso alone or Foley alone. And so combination cervical ripening was not required as a part of our induction protocol, but was recommended. We also know that, this is just more about combination cervical ripening, which, I think the first concept here is that like time to delivery, people are like, oh, I don't care, right? Like it doesn't really matter. But I think at the end of the day, when we think about the bigger picture, we know that time to delivery is associated with patient satisfaction. And that we talked about the strain on resources with increasing induction at the beginning. It does have sort of healthcare implications as well. And so there was a meta-analysis looking at mesofoley versus meso alone that showed a 4-hour shorter time to delivery and also showed lower rates of NICU admission, meconium, tachysystole, when combination methods were used. The amniotomy piece, so we mentioned that was part of the protocol, is one of the more controversial things. There isn't a ton of great data supporting any one thing. This is somewhat of a smaller study of about 585 women who were randomized to either early amniotomy or standard of care, had to be beyond 4 centimeters. And there was a shorter time to delivery by about 2 hours with more deliveries in 24 hours with early amniotomy without a difference in C-section or choreo. But then is earlier than that amniotomy even better? This was 168 women that term that were randomized to amniotomy when the Foley came out, regardless of how dilated they were during an induction versus, PIT first followed by amniotomy once they had regular contractions. And in this case, there was a higher C-section rate in the early amniotomy group with no difference in time to delivery. So I think it really depends on the situation. This is a systematic review that kind of put together 4 studies on this topic that again showed a similar risk of C-section, but a shorter time from induction to delivery of about 5 hours with early amniotomy with no other maternal or perinatal differences. And then frequency of exams is the other sort of major piece of our induction protocol. And again, this is a little bit of a difficult thing to study, but when we looked at about 200 women randomized to Q4 hours in latent labor during an induction with the goal of amniotomy when feasible versus only of indicated exams, there was a faster time to vaginal delivery by about 7 hours in the Q4-hour exam arm with no difference in mode of delivery or infection, which people are always questioning. And then another one, about 100 nulliparous women, but these were patients in spontaneous labor, randomized to exams every 2 versus 4 hours, and that had no differences at all. And certainly there are some observational studies that associate more exams with decreased birth satisfaction. So it is a balance to sort of think about. Okay, so that was my foray into evidence. Now we're going to come back to the study here. So essentially we picked these components based on some multidisciplinary feedback to do this 2-year pre and post implementation study. We implemented at Site 1 in 2020 and in Site 2 in 2021. We picked some concrete implementation strategies to try to get this into care. And we didn't spend too much time on what that means, but these are ways to help get a clinical practice baked into care. And there are ways to do this in an actual evidence-based way, which is time-consuming, but a great way to do this thing, where you actually do a standard sort of barriers assessment, and then you use a mapping tool that can actually pick the right implementation strategy to go with that barrier to get your thing into care. But in this case, this was sort of done just a little bit more less rigorously than that. But stakeholder buy-in, training and education, and then audit and feedback was thought to be really important here. And so we essentially sent Q3-month feedback to all the clinicians about how they were doing at utilizing these components throughout the study. And so these are the results that were just published a few months ago of this trial. This is a really big slide table. It's an ugly table. But essentially this is looking at each of 8 components of the protocol that we could concretely measure and look before and after, did we actually increase utilization of the protocol components, right? That's the first question before we can even think about looking at our clinical outcomes. And this was like the saddest thing, right? It's like we did all of these like intensive strategies and so much planning to get this into place. These are places that I work at clinically. And a couple of the things we were already doing so well, we had no room to change, right? That's one piece. And then there were a few things that went up, right? It was frequency of latent labor exams every 4 hours, and that went from compliance of 35% to 40%. The amniotomy at 4 centimeters went from 46 to 55%. Placement of an IUPC when appropriate went from 32 to 52%. Like these were changes, but they weren't amazing. So, I think that is one piece of this. We did see overall in our outcomes that there was, well, first, there was absolutely no difference in C-section, which was my primary outcome. We did see a significant reduction in composite maternal morbidity from 9% to 6%. It seemed to be driven by differences in blood product transfusion, postpartum hemorrhage, endometritis. But this was where, I thought things were really interesting, which was we basically came up with a what would look like an as-treated analysis, essentially comparing only patients in the post-implementation group who actually had more than 75% adherence to the protocol components that they were eligible for, and compared them to our pre-implementation group. And here's where we saw all the differences, right? So, there we had a significant reduction in C-section rate and time to delivery and choreo and maternal morbidity with no difference in neonatal morbidity. And so it told us if we had done a better job, maybe we would have done a better job. And so that's where, again, sort of these implementation science kind of qualitative pieces can come into play and be really helpful in figuring out how to move ahead next. This was work with clinicians. We started with a survey that had a standardized acceptability scale that we incorporated in. There's lots of validated measures around these things at our unit. And it told us, here are the components that were least acceptable to people, right? So this is the percent of clinicians who said that they were completely comfortable with this recommendation. Some of these things had only about like 40 to 50% of people who said they were completely comfortable with it. And it's that frequency of latent labor exams and active labor exams and the amniotomy pieces that were some of the biggest challenges. And so moving on to qualitative interviews, we used these acceptability scales to decide we're going to pick people who really liked the induction protocol and people who really didn't, so that we can make sure we interview all of those people and get an understanding. I think in general, people told us standardizing care is good. We want to reduce C-section rates. We feel like having an intervention like this will make care more equitable, reduce variability between clinicians. We're going to be using more evidence-based practices. I like having a tool to refer to for other providers and say, like, this is what we're going to do because this is what it says we're going to do. But there were lots of barriers and facilitators that came up, right? And you guys can imagine if we were trying to make this happen at your site, all the things that would come up too. Time is the answer for every clinician, for every intervention across the board, right? We are all busy people. So, that was always impeding the ability to implement the protocol. And time specifically in terms of thinking about coming together to do a cervical exam, right? You need the nurse to have time, you need the physician to have time, you need the patient to have time, the patient needs to not be in the bathroom, and everybody needs to come together to do that cervical exam. And that is not easy. And there's also, then you all got together in the room and then all of a sudden there's an alarm and there we go. So, I think that all those pieces are hard. I think clinician resistance, and when I say resistance doesn't mean inappropriate resistance, just, there's disagreement about best practices around different philosophies around labor induction. And then there's clinician perceived patient resistance, even though they didn't really know how patients felt about any of this. Clinicians reported that they feel like there were patients who just have an aversion to any interventions on principle and that they come in with preconceptions about the interventions that they then don't want to do them. So there was a lot, I'm going to skip the domain. I went from domain 2 to domain 3 of these interviews because we actually went through each intervention with clinicians in this study, and then again with patients to understand each thing. What are the issues with amniotomy? What are the issues with cervical exams? But we came up with these sort of recommendations for implementation moving ahead, which is, again, comprehensive clinician education involving patients as active participants prenatally, kind of similar themes to previous stuff, is that if we can engage people early on in understanding why we might recommend these things, that might be helpful. One of our fellows did the patient acceptability piece of all of this, small study, only about 11 patients, I think, looking again at an overall protocol as well as each component and getting their feedback on it. These are patients who were already delivered after an induction. They in general, the conversations with patients around induction seem to always center around pain, understandably, as well as the baby and the possibility of C-section. Most told us they had never even heard of meso or Foley before coming in for a scheduled induction. But then when they heard about it, they felt like it sparked little concern. The Foley, there was some apprehension, but at the end of the day, they said it wasn't as painful as expected and just pressure. Pitocin, they had gotten a lot of concerns from outside sources, right? I think there's a lot of Pitocin misinformation out in the world. But for AROM, actually, most people, interestingly, clinicians told us that patients didn't want to have an AROM. All the patients in this study felt like it didn't matter to them about ruptured membranes. And then cervical exams, people told us that they had a wide variety of expectations around it. They thought it was going to be every hour. They thought it was going to be one and done, but that it was fine at the end of the day. So, I think this was a small study, but there's some really great quotes in this paper. But, I think that this idea that prioritizing pain management, having detailed counseling, and a focus on speeding up labor was the priorities of the patients who were involved in this. And if we can kind of center some of the future work around that. I'm going to come back to the disparities piece just to tell you that this didn't work. Not everything we do is successful. And so, what we found in our study here, where we were trying to reduce disparities in outcomes, was that we had a significant disparity in our pre-period in both increased risk of C-section and maternal morbidity, even when controlling for other differences in groups. And in our post-period, we still did. So we did not change our disparities with implementing this protocol across sites. There were no differences in neonatal morbidity, and we did look to see if the protocol was implemented differently, were there components being used differently across by race, and there was not. The questions like, why didn't that work? We had a really low C-section rate actually in both our pre and post period overall. A lot of our components, like I said, were already well implemented, or it's just that, we know our racial disparities are really multifactorial and really complex, and that this just wasn't able to impact it. I think that our future plans are to look at sites with really high C-section rates and we're really not utilizing any of these components, and think about whether or not there is still a place where this could work, a context where it could make sense. But that's, a future study, and we'll hopefully incorporate some of both the clinician and the patient qualitative work that we've done to move that forward. My conclusions for the talk today are, I think that we have interventions that take bias out of clinician decision-making that have the potential to improve outcomes overall and reduce disparities, but there's still a lot of work to be done here. Our busy and high acuity world of L&D especially has those opportunities, as we have to act quickly, and often that's what leads to acting with biases. I think that when we think about doing any interventions or any change, thinking about reach from the very beginning can be really important, and holding ourselves accountable throughout the process. But there's really, hopefully, so much more work to be done in these spaces. And thanks to a million people who help with all these projects. And that's it.
We have time for a couple questions.
I talk really fast, sorry.
Hi, excellent talk. Do you guys use those educational ME videos at Penn?
I don't think so. Should we?
Well, I'm just wondering, I did my residency at McGee and we used them there, and I am at Kaiser in Southern California now, and we use them there too. But it might be, and at McGee, and this was I finished my residency in 2010, but at McGee, patients had a delivery education video that they did. And I wonder with some of the stuff that your fellow found, and also some of the stuff around sort of increasing acceptability of these, making everybody's lives easier, if those, one of your implementation strategy recommendations was potentially patient education videos. And so you could have a little, that might be a good thing to pursue if Penn has it built into your EHR.
Yeah, I love that idea. Yeah, I was telling Laura earlier that one of my postdocs now, she does all work on social media and maternal health messaging, with the idea of, analyzing what kind of messages are going out to patients, and what's getting the most engagement, who's creating those, does it have misinformation as a part of it. And, I think that her next piece is around labor induction. And I think, I think thinking about tackling it in the moment is really helpful, but I also have this theory that we need to be tackling it from the beginning of the pregnancy, because I think that people get bombarded with misinformation, very early on. And so my hope is that we can find ways to infuse social media with the types of messages that do get engagement, but also have correct information in them, regarding these pieces. So.
Well, and you have that advisory board.
Yeah.
Your equity board could help you create 30-second, minute-long videos that could be part of a series, for.
Yeah.
Can you talk a little bit about implementation fatigue. For example, like I saw that Epic board and all the dots, and all I could think of was like a pre-hemorrhage risk assessment we tried doing one time, and it just ended up being dots on a screen that nobody looked at, and it was like infuriating.
Our hemorrhage one was the same way, so I'm with you. Yeah, you know what, I totally get that. I think that, you know, I run OBQI at my site, and like, it feels like every meeting, right, comes up with like 2 or 3 new things that we need to be doing, and that feels really overwhelming. And then how do you sustain any of that? So, you know, I think that one way to think about doing these interventions is that they need to be done in a way where they're sustainable without, you know, the active participation in some ways. But also, you know, I think that my dream is one day to study like that we just need someone whose sole job it is to sustain them, right? Like it needs to be that that person runs the audit and feedback report and sends it out for this thing that we know that that's what works for that thing. Then, you know, for the postpartum hemorrhage risk thing, like, is it that we need to call up to L&D and go through like the, you know, the things that need to be done for today from a quality perspective? And I mean, it's only additive then, but you know, at least it's like, you need like a quality person's job it is to like be the sustainment officer of like all of these things. So I'm gonna study that at some point, but you're right. I don't have an answer for that. I think it's totally true. I think this is you can't just add without, you know, removing things that don't make sense. I guess the last thing I'll add to that is that de-implementation is a whole another field, and some of my colleagues in the implementation science specialize in the science of de-implementation and the overdoing of things and how to take that out of practice. And so, you know, I think that there's a lot of non-evidence-based things that we waste our time on every day. And if we could theoretically remove some of that stuff, maybe we'd have more time to do the things that matter.
Thank you so much, Rebecca.